Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago. My name is Megan Phillip, and I am the Executive Director of HC3. We are a mission-driven platform proactively seeking uncommon alignment to improve Chicago healthcare's ecosystem. As we continue to navigate the ongoing COVID-19 pandemic, HC3 launched the Transformation Series to address how we can leverage our collective resources to foster solutions and help rebuild our communities. One of our priorities for the Transformation Series is to consider how we can promote solutions to radically improve the healthcare system's performance and reach. Today's discussion will be centered around the future of access to care, and we will be joined by some experts in the field developing and investing in these solutions-based approaches. Before we dive in, I have two housekeeping announcements. This morning's discussion will be recorded and shared on our website, www.hc3.health, for later viewing and sharing. As we hear from today's experts, if you have questions, please use the chat function, which will be seen directly by our moderator, who will do his very best to address them during our audience Q&A. Without further ado, I will invite today's participants to turn on their cameras and unmute themselves. Anna Hahgooie is a managing director at Sandbox Industries and primarily focused on their Blue Venture Fund portfolio. Salma Khaleq is the Vice President of Provider Strategies and Partnerships at BlueCross and BlueShield. Lee Shapiro is a managing partner at Seven Wire Ventures, and moderating today's discussion is Stephen Collens, the CEO of Matter and one of our co-founders of the Healthcare Council of Chicago. Thank you all for being here.
Well, Megan, thanks so much. I always love being part of HC3 programs. Great to be with you and great to be with really a terrific group today to dig into the topic of access. And, COVID-19 has changed, so much, at least on the surface, when it comes to health and healthcare. And what we want to dig into today is specifically what's changed with regard to access, for the better, for the worse. What have we learned, and what changes are here to stay? So, at the onset of the pandemic, almost every organization, every business, every entity was scrambling to ensure the health and safety of their employees and patients and members and customers. And they were a lot of sort of ad hoc fixes and patched together solutions that were implemented very rapidly. At the same time, though, it seems that the pandemic has not just temporarily altered, but permanently changed how we do business across the board, and in particular, how the healthcare system engages with both itself and also with patients. So Salma, I'll start with you. And one of the things that experienced the most rapid sort of change in dynamics was telemedicine. And so where have you seen growth in telemedicine? Where has it sort of receded as the pandemic has, we've sort of moved through the pandemic, and where do you think telemedicine is going as a facet and an ongoing part of our healthcare system?
Great, thanks so much, Stephen, and great to be here this morning. We saw a pretty rapid increase in telehealth access and utilization right at the beginning of the pandemic. When we measured it, it was about a 465% increase over prior year, which is a pretty dramatic use of the modality that we had never seen. We've always had access, but in a limited way, through a third-party vendor, as opposed to being able to pick up the phone and call your provider, FaceTime with your provider. So that is definitely one of the contributing factors. I really think the ability of the individual to connect with their physician has modified the way that we think about telehealth on a go-forward basis. The thing that I think has dramatically persisted throughout this time, and we still see it, is a replacement of face-to-face behavioral health visits with telehealth behavioral health visits. That's a trend that seems to continue. Actually, about 60 to 70% of our spend at any point during the last year was behavioral health telemedicine within that telemedicine utilization. So it's been a really great modality for expanding access to behavioral health. And I think there are definitely some additional opportunities for us to continue to think about how to innovate in that space and continue to increase access to much needed services. In terms of where we see it going in the future, definitely here to stay. Not something that's going away anytime soon. I think the critical question for providers that are looking to be in the telemedicine space or provide that service is how well does it integrate with their value-based arrangements? How well is it going to integrate with coordinated care and the delivery of coordinated care within risk agreements? I think those are all sort of TBD questions, but we're on a path, and it was great to see Chicago and Illinois really Illinois providers respond to this by making access available rapidly and quickly.
And I guess there's different ways to think about access, Salma. So one of those is access during a pandemic when you simply can't get to, there are barriers to going to see your clinician, your healthcare professionals. The other is on an ongoing basis, the role that something like telemedicine can play in providing access to a greater percentage of the population to services that were otherwise challenging to get to. And do you have indications at this point, or do you have a sense at this point as to whether growth in telemedicine will truly help create access for people who otherwise had barriers, or whether it is more of a convenience replacement for people who were already going to mental health providers or others anyway?
I think what it looks like right now is the latter, really convenience extender, not necessarily a good new access point. And I think that's where there's definitely a lot of opportunity. And the reason I say that is because I feel like there are still a lot of barriers to care. And I know we'll probably talk about health equity, but a lot of barriers to care that make it challenging for telemedicine to really do what it can do, which is extend into everybody's homes. So I think there's certainly some opportunity. What we've seen so far is really replacement of existing care, which is a good sign in and of itself, right? If we had seen an increase in care, I think payers would be a little bit more resistant to continue to keep that modality as as open and far-reaching as it is today. So I think it's a good sign, actually, because to the extent that we are seeing the actual care being replaced with a modality, it means it's effective, it means it's working, and it means that it's not something to fear on a go-forward basis if you're on the payer side.
So Anna, you kind of have a role. You sit sort of on a most simple basis in between a large number of Blues plans and innovations that are being developed. Are you seeing interesting solutions or technologies when it comes to telemedicine that point towards sort of a greater degree of access to underserved populations, underrepresented populations, and at the same time, the conversations that you're having with your LPs, are they consistent with what Salma has shared from the BlueCross of BlueShield of Illinois, or are you seeing differences regionally?
Yeah, so all good questions. So I guess maybe I'll start by sharing a little bit of our perspective on sort of telemedicine as a standalone. I'd say, we view that as sort of just table stakes to any new care model. And so to the extent you can create or open up that convenience and access to get to some clinical endpoint or some consumer experience, it's got to be part of whatever that offering is to the market. And so I think in some ways the sort of days of the big telemedicine platforms has run its course a little bit, and Lee can absolutely speak more to this, but some of, I think that the bringing Teladoc and Levongo together was sort of a recognition that telemedicine for telemedicine's sake isn't necessarily the future. It was absolutely important to Salma's point, to show that you actually could have high value clinical interventions and get to clinical endpoints using remote interactions. But as far as sort of more of a future world of where we're headed, I think the ability to connect remotely is just a piece of whatever you're trying to solve. And so then bringing up the question of access and equity to communities that have historically had barriers to health, to me, I think tele is not enough. So much of the barriers have to do with trust and with sort of the belief that, as you engage, there's going to be someone looking out for you and your best interests. And so I'd say we've been more interested of late in around that topic to say, how do you partner with people that are in the community and adjacent to the community, or are important gathering places within the community, to start to create an entry point for then, whether that's telemedicine or remote, chronic disease management programs, or any variety of sort of clinical interventions or endpoints. But at the end of the day, if the initial sort of onboarding or access point isn't through some trusted agent of that community, of that neighborhood, the ability to really solve some of these problems around access and equity, I think, is limited. And so, we've seen companies like in our portfolio, Wider Circle, who helps neighbors connect with neighbors to create circles of trust that then are used to facilitate transportation, meals, health screenings. We've seen young entrepreneur focused on leveraging barbershops in Black communities to be a hub for health, and where those conversations start. So a company called LiveShare. So those are the things that I think are pretty interesting, of like, how does a barber talking to somebody about screening for diabetes take that conversation, leverage telemedicine and the ecosystem that all these other entrepreneurs are building to actually start to close some of these gaps around access.
I'd like to see a barber to talk about anything, actually. In the past year, that's been very infrequent. And Salma, just, one thing that you had mentioned in terms of the thought process around telehealth, I'll talk about that more broadly in terms of thinking about the range of virtual connections that can happen, not just a video visit, but by text, by voice, by SMS messaging on the phone. Like there's a number of ways that we can facilitate remote interactions. I'm actually hopeful that what we see is an expansion in terms of delivery of services. Taking some of the things that used to require people to come into an office that now allows a provider to practice at the top of their license, and thinking about ways that we can also extend access. So oftentimes I have a mindset, because I grew up in kind of the city of Chicago, and lived in a dense urban area. I think about access in that environment. But when I think about access into rural communities, and access into places where frankly, the availability of care was probably challenging. People literally have to get in a car and drive an hour and a half, 2 hours to go see a provider. Now having access to some of these tools and services, I think, has opened us up in ways that is able to provide an expansion of care and delivery of services into communities that may have been underserved with healthcare in the past. What I also start to see is ways in which these modalities are being used to reach into communities that were difficult to reach before. There's a company in our portfolio, Consejo Sano, that works with managed Medicaid and state Medicaid plans to reach individuals principally through text, but to go ahead and to engage with them and to start to have a dialogue in a way that they understand, that's culturally sensitive, to talk to them in the way that they understand healthcare, not the way the healthcare system talks about healthcare. We've seen other companies that are reaching out into similar communities, but to try and help individuals who are recovering from an addiction to gain access to services they need, and to support them through peer counselors. Those things are really difficult to do if you try to get someone to go someplace. And using these modalities to meet consumers where they are, to deliver health, I think is a very important part of the way that we're using them to expand access.
Do you see that working so far? I mean, I love the example that Anna gave of barber shops. I kind of wish I'd started that company, even though I don't know a thing about barber shops. But that's really interesting. And you, I mean, you can put on a variety of hats, but your firm invests in, this thesis around informed, connected. I don't remember exactly the vernacular, but informed, connected health consumers.
Health consumers. Thank you.
And there's a lot of ways to think about that, but one of them is really empowering people to make better choices, to have better information, to be more a part of the decisions regarding their health, as opposed to being really passive actors who are just sitting back and waiting for it to come to them. And are you seeing any changes, whether sparked by COVID or otherwise, that suggest that that momentum or that ethos can help expand access?
So there are a lot of pivots that had to occur during COVID, and a variety of challenges and changes that we all had to adapt to, and companies in our portfolio had to do that as well. One of them, called School Care, was working principally in public schools. So those are traditionally in more of our underserved communities, in helping to understand health needs of families by working through the students in the school. So it starts with a visit to a school nurse, or in some cases they don't have a nurse, it might be a school administrator, because a child is feeling sick at school. Well, how do you document that, and how do you record that, and how do you use that to maybe leverage it in ways to reach parents to get the child into care services that they otherwise might need? Well, when schools closed, okay, now you had actually some students who really had a lot of problems kind of accessing the services that they needed to stay in touch with schools. And so this company had to now kind of pivot to say, how can we reach kids who may need services? Like, they still need to get their medications, or they still need to find ways to be able to deliver them things that they needed to get delivered that they were only getting at school. How do we get them to their home? And so working with a number of their clients, folks like Centene and Molina and United Healthcare, to work with them to now start to access, again, principally through people's cell phones, to reach those kids and to either talk with them or to chat with the families to get them the services they need. So I do think that whether it's the barbershop, or whether it's the school, or whether it's the church, that thinking about access to consumers, we have to think about it in different ways, because the pandemic made it really challenging for people to get to see doctors. Well, it's also challenging for people to get to see doctors under normal circumstances. If you don't live on a bus line in a community that is able to give you close access to doctor's offices or healthcare services, you're just not going to go. And so what can we be doing to deliver those services to people in those communities? And I think that's part of what we've started to see evolve through the pandemic.
Salma, I sort of turn to you on that note, and Lee brought up a good point that access means, you can look at it through a rural lens, you can look at it through a sort of an urban lens, but just picking one of those, whether it's underserved areas of Chicago or rural parts of Illinois, all of this digital innovation that we've kind of seen, and some of it being combined with barbershops and schools. To what extent have you seen in the years leading up to the pandemic and then during the pandemic, digital sort of solutions exacerbating issues around health access and health equity versus being the solutions? And are, from your seat, are you seeing any shifts in recent times towards more of a focus around access and equity with digital solutions, or how do you see that shifting?
Yeah, that's a great question. I think it all comes back to what the business model is of the organizations, that the organizations that Lee and Anna talked about are really centered and focused on a Medicaid population. Given that we serve employer groups and individual customers and Medicaid and Medicare beneficiaries, I think that what we see is a lot of innovation in the digital space for employer groups. We see a lot of focus on how do we get an employer to purchase this particular product as an add-on service, which I do think exacerbates the access divide across the types of where you get your insurance, sort of where you get your coverage is really dictating whether or not you have access to some of these additional services and additional tools through your programs. And there are certainly areas where we've looked to supplement and bring similar solutions into the Medicaid environment, bring similar solutions into Medicare. But it's a challenge. It's a challenge because it's not necessarily considered part of the benefits. Up until last year, Medicaid did not even allow for providers to bill for telemedicine. So I think it's been an evolution, certainly, and there's now a realization that everyone can benefit from digital transformation. And I think the question is, how do we continue to focus on the segments that are in need, and the segments of the business that might be a little less lucrative for a startup, but make a lot of sense in terms of where access is challenged and where those solutions can really be powerful contributors to bringing the care delivery together for the consumer.
Anna, are you seeing models of that address some of the concerns that Salma was talking about? So, essentially, solutions that focus on Medicaid populations, or should Medicare populations more so than kind of commercial members, that can have that can kind of take the potential or the promise, I think, that we would all believe in around the possibility of digital solutions to really improve access and improve equity, and kind of turn those into a reality.
Yeah, so I think this is, for those that are spending their careers in healthcare, it's probably well known, but the power of government in sort of helping open up the gates for innovation and a focus by entrepreneurs is really important. And so we've seen it, over the last 15 years in Medicare Advantage, where the rules of the road got much more clearly defined as to the playbook of how to do well in that product and in that book of business. And it's, has manifested into companies like Oak Street Health and others that are built for purpose to essentially optimize around the structure that government has set out to reward quality, to reward people for taking on risk and complex populations. So I share the Medicare example as one because I think Medicaid is, many decades behind in sort of conforming around similar structures and strategies, but we've seen a lot more innovation and clarity by the states as to what they're going to reward managed Medicaid plans for in the bid cycle. And it's unique programs around special populations like substance use disorder. It's around focused on engagement and access and equity. And so I think the more that states get very clear and ideally consistent state by state around the types of programs, populations, and things that they're going to measure, that the managed care plans will get scored on, the more impetus there is for entrepreneurs to focus on that book of business and that population. So I will say, like, I think we've seen a 10x increase in the number of startups focused on managed Medicaid over the last 3 or 4 years. They're still focused on sort of subsets of a population. So substance use disorder, serious mental illness, or episodes of care like maternity. So there's this focus on, like, if you can understand the incentives, understand the patient population, and take those dollars and restructure a care model to deliver better outcomes, better equity, improve access, the rewards are starting to be more clear. And so I think because of that, there's just been a big influx in focus on that book of business. So I'm excited. I think it's going to be sort of the next wave of innovation. And I think that's really good for the country to be focused there.
I think that's really encouraging. I mean, 10x obviously is a sort of a back of the envelope calculation, but you know, even if you're off
base,
that's a meaningful change in where entrepreneurs are focusing. So I think that's very encouraging. Lee, so Levongo, which a company you really helped build, is, you know, arguably one of the most important, successful kind of models that's emerged in recent years, that harnesses a number of different pieces and puts them together into a novel way to deliver healthcare solutions to populations, you know, people with diabetes, people with hypertension, and those you know, chronic conditions cross a whole spectrum of types of people, you know, who have our commercial insurance, people who are on Medicaid. How did you find, you know, Anna talked about government and the importance of government, and you know, how did you, in building Levongo, where did you find yourself drawn in terms of focusing on different populations, and how has that evolved?
Well, Levongo, you know, started. We had a lot of experience on the team that had worked with providers, and actually we came to a realization relatively early in the company's gestation that working through providers was going to be challenging, because the business models were a little bit off from what it was we were trying to do as a service to individuals. Providers thought of a glucometer, even if it was a smart glucometer or a smart blood pressure cuff or a smart scale, from a DME mindset, a durable medical equipment mindset, and that gets reimbursed in a certain way. And then, you know, and that gets paid for in a certain way. And then there's a visit charge, and you have to look at data under a remote monitoring code, and that looks at a different slice of it. And you do that once a month, and so we were saying, well, like, that doesn't make sense from the standpoint of your consumer, of the individual who happens to have this chronic condition. And we found a lot of receptivity with self-insured employers. They're paying the bill. They basically said, if you can help us save money by avoiding unnecessary visits to doctors' offices and unnecessary visits to ERs, then we'll pay you a fee. And we basically looked at how much they were spending on a population that was roughly 6% of the individuals that they employed. It varies, of course, based on company, but in general, 6 to 8%. But yet those individuals accounted for outsized costs in the population of overall costs that employer was bearing. And so in that light, we were able to demonstrate meaningful first-year savings to those employers, and even asked them to let us go at risk and share those savings. They say, no, we like this deal. We're happy to pay you a flat rate on a monthly basis. We'll keep more of the savings for ourselves. And as we extended into other chronic conditions, that model held. What we found was working with innovative health plans, many of whom are members of the association and are also partners in Anna's fund, that they bought into this idea of providing these services because they also saw savings first with their national accounts and then ultimately building it into their fully insured book of business. And we were dealing with people all across the country, in some cases even outside the US, but all across the country in different stratas of age, income, all different demographics. And you needed to think about how it was that you communicated with those individuals differently, the way in which you provisioned things for them. So for example, in certain communities, especially in the South, they wouldn't talk about having diabetes. They would say, I have a case of the sugars. And when you were reaching out to them and trying to get them to engage, you needed to understand the language that they use to build that trusted relationship with them and to bring them on to a service like this, and then to have dialogue. You can't work with an individual who lives in South Central LA and talk to them about their diet and say you need to eat more fruit and vegetables when their diet consists of rice and beans and tortillas. You have to understand what's the way in which you can start to think about nutrition in a context that understands what resources they have available. And so as a company, and for many of the companies that Anna and I work with, they have to appreciate that if you're going to meet people where they are, you have to understand their circumstances and be able to, I think, build that trusted relationship with them in ways that prove that you have that understanding.
Is that, just dig in a little bit on that more and put it in the context of access or equity. Yeah, I think what you just described is like a perfect journey, starting with, in some ways just how kind of cockamamie the way that we pay for healthcare services is, and then moving and finding a model where you can align the benefits to people with an economic benefit to somebody who's willing to then pay for the solution. And that's often hard to do in the way that the entire healthcare system is organized. Do you have a sense that by kind of creating smarter ways of doing what you did with Levongo, and that kind of hopefully paving the way for other solutions now, that will ultimately have a beneficial impact on access? Or is that a different issue? Is it just it's a different set of questions, a different set of challenges?
I can see where there's a common thread there, Stephen, but it's probably dealt with as separate issues, honestly, in my experience. I'd certainly love to hear what Salma and Anna, have to say about it. My hope is that there's a recognition that services, innovative services, can provide for needs of individuals in ways that are not traditional. I mean, we saw this during the pandemic where health plans were focused on delivering food to individuals. Like, that's not covered in anybody's formulary, but yet there was a recognition that healthy food was really important. I heard Gail Boudreau talking yesterday about, the focus that they're going to have coming out of the pandemic on access to quality food. And so I think that this is something that we need to start to build into the systems rather than trying to find a way to make the system adapt to these solutions.
Yeah, I think that's really interesting, and it's so Salma, I'll turn to you from your standpoint. I don't know whether BlueCross BlueShield of Illinois is delivering food and taking steps like this, but obviously you're doing a ton when it comes to equity and when it comes to access. And is there something that you've seen or something that you've piloted or tried that you're particularly excited about, that's kind of moved the needle when it comes to access and equity.
Yeah, I think, you know, we've spent a lot of time really thinking about how to embed ourselves within the community. So to the earlier points about, you know, the barber shop and being able to access the member where the member is and in the member's language, I think from our vantage point, embedding ourselves into the community in support of that community is an important facet of our strategy. So the Blue Door neighborhood centers offer wellness and fitness classes, and we took them all virtual last year in order to support those communities and people that began frequenting the Blue Door neighborhood centers when we put them up. Beyond that, I would say we're interested in a lot of things. We made several investments last year in community organizations, and this year we looked at made an investment in housing. I think for us, the concept of solving for social determinants of health, even outside of the system, because it's not a covered benefit, is community-based. And it's really about how do we use our reach within the state of Illinois to make some kind of impact. What I'm really excited about is translating that into how we pay for care, because I think that that's really when things begin changing. And providers may think about things a particular way because they're paid a particular way. Payers are responsible for ensuring that providers think about payments differently. And the concept of the fee-for-service mentality is what really gets us into thinking about which specific code is going to be reimbursed, as opposed to thinking about what's best for the consumer, what's best for the patient. And what we've done for the last couple of years is actually embedded health equity metrics and requirements into our ACO contracts, into our HMO contracts, inclusive of implicit bias training, and ensuring that we're measuring specific quality indicators for underserved populations, ensuring that providers have the tools and capabilities to actually collect that demographic information, which interestingly enough, many don't. And then, during the pandemic and into this year, we're working on a hospital program, which is the first time that we've taken a stab at how do we make sure that our residents and our medical students and the folks that are serving our communities are actually reflective of those communities. Because we've got a lot of graduate medical education in Chicago, but we don't have a lot of diversity in our Chicago clinical workforce. So I think the question is, how do we make an impact? I think programs like that, to me, are exciting. We've had a lot of participating provider interest in this and alignment, because I feel that providers are trying to figure out the right things to do, and we're trying to put some rules out there. They may be wrong, and maybe we need to pivot a couple of years from now, but we're trying to put some guidelines out there for how to help them be successful in this space. And it starts with, do you understand your population well enough? Are you collecting your data? How does the data look? Are you measuring quality on a cohort basis so you can really understand variance in quality performance across populations? And are you hiring and ensuring that there's a diverse workforce in your clinical faculty in particular?
So I want to come back to a theme that you just touched on, but I want to, there's several questions that the audience have asked specifically related to telemedicine. So before we get too far into that,
Stephen, sorry to interrupt. Can I underscore something that Salma said? Because I think it's so important in knowing that this is a Chicago community on the phone. But the point is, if we want to start solving these problems, they're incredibly complex. They're personal. There's a ton of legacy and history about why things are the way they are. And so the point that Salma made about, we're going to put something out and it will be wrong, and let's work together to figure out how we can learn from that and iterate and actually make some progress. And I think, having observed the healthcare system for the last 15 or 16 years of my career, it's so hard to accept imperfection, I guess, in healthcare. And so what we end up with is just layers upon layers of new rules versus an iterative process that we see so often in the entrepreneurial world that actually is what it takes to do something different. And so just that idea of the existing payers, the existing providers, the existing stakeholders having that patience and participation in sort of an iterative process that is going to be wrong at first try. I just think it's so important and such a cultural shift in healthcare, is instead of pointing fingers at each other, you know, there's more of a collaborative effort to try to figure it out and get it right.
Yeah, that's absolutely, you know, our approach and the way that we think about working with providers. I think it's challenging to solve many of these problems. On our end, we had to get comfortable with the idea of making an investment, right? On our end, we had to get comfortable with the idea of developing something that, you know, we have a little bit of expertise in my colleague and the Illinois CMO, Derek Robinson, but don't necessarily have a lot of depth of experience in, particularly around, you know, aligning incentives in hospitals in particular. But I think at the end of the day, if we refuse to pursue incremental progress, if we refuse to pursue piloted programs with digital solutions, I don't think we'll learn. And we're learning a lot from our relationship with Levongo and Amada and you know, MD Live and a variety of third parties that sometimes our employer groups bring to us. And sometimes we dig out and find and try to implement to see if we can make a difference. And it's a fail fast mentality. You know, can we quickly figure out if this works? Minimal investment, minimal viable investment, and if it doesn't, let's back out. But when it comes to working with providers, I think that's a different story, because there's a long-term relationship there and a long-term opportunity to iterate together and to work on solutions and to make improvements to programs that we put in place. And we've been doing that since 2017. And we'll continue to do that, I think, into the future.
Well, one of our core values at Matter is never stop experimenting. And it's something that good entrepreneurs do inherently and have to do well usually to succeed. And it isn't always, to Anna's point, and to what we see among larger entities. So very encouraging to see that kind of direction. So one of the things that I think was implicit in what, Salma, what you were saying earlier was really around quality, and we haven't explicitly talked about quality of services much in this conversation, but quality makes a big difference. And it's one thing to expand access to, you know, a mediocre set of services or a mediocre set of healthcare, and it's another to be able to kind of measure and identify and incentivize quality. And that hasn't, you know, I'll just turn to you. You know, what is your sense of where, you know, where from a payer lens, how is that evolving, and how might that affect solutions that are being developed or permeated that can have an impact on access and equity?
I think we've done a lot in this space, especially as we've entered and expanded into government business, you know, over the last decade. It really has changed our philosophy around incentives and how to create those incentives in alignment with our providers in particular. I think on the provider side, there's been greater receptivity for putting quality measures in the contracts. There's been greater interest in it, as long as we can define a set that is common. I think that the really challenging aspect of quality is how many metrics there are and how much variation there is. And in some specialties, maybe there might be a dearth of metric availability. Like, you know, there's a lot in orthopedics, but not a lot, you know, for rheumatology. So I think that's one of the challenges that we're grappling with, but we believe it's a foundational aspect of the way that we do business. We've actually internally developed a scoring mechanism for every provider in the state to try to understand where are they on quality, on efficiency, on appropriateness. How do we understand their performance relative to their peers, and to what extent do we want to begin to leverage that information for the consumer so that they can be informed about what you're going to get when you show up at that particular provider's office. But there's work to do there. It's, again, imperfect, and we have to be comfortable with the idea that we're not going to get it right, the first time around. But if we don't explore those opportunities, I think we miss the chance to really make an impact on healthcare, which we believe we can because of the depth of our business and penetration in the state.
And to what extent are Lee, I'll just stick with you for a minute. So Lee was talking about the model of Levongo and sort of trying different things and ultimately moving to a risk sharing, whether employers wanted it or not, model where that really aligns the economics for employers with the economics for Levongo, with ultimately improved outcomes for the patients or the connected health consumers who are have diabetes or have the sugars, have hypertension. To what extent are you seeing, or are you pushing out more models like that that innovators can latch onto to develop, design, scale solutions that ultimately can improve health of diverse populations, as well as fit into an economic model that makes sense for BlueCross BlueShield of Illinois, ultimately?
I think often what entrepreneurs struggle with when they're working with us is how large of an organization it is and how difficult it is to actually share the data that we need to share in order to be successful in some of these models and in order to empower our self-funded customers. I mean, no doubt, we've got a lot of legacy infrastructure and a lot of effort underway to modernize, but at the same time, we're in a world where it is often challenging to integrate in the way that we'd like to integrate. The collective health investment that you might have heard about from a month back or so is really about having a platform that we can integrate solutions into, and ensuring that where an employer group is looking for options, that is a more cohesive experience for the member. Because it's challenging to fragment care. If you're diabetic, you go here. If you've got cardiac disease, you go here for your care. And different solutions that employer groups are procuring for their customers make it really important that we have a mechanism to bring these pieces together so that individuals can access those services and see them collectively in one place. That's part of our sort of longer term where we're going and what we think we need to do in this space. And then on the provider side, I would say, incentivizing and continuing to work with providers that are interested in taking risk and thinking about the person holistically, but supporting those providers in areas where they may not have those capabilities. And behavioral health is a great example where we've heard consistently, a need for added support from the health plan through a digital modality or a tool, even if you're taking risk, because sometimes you just don't have the expertise on staff or available. So I think that supplementation for our providers is also very important, because for us, they are the platform to bring things together for consumers and some of our products. And that's a really important aspect that we'd like to continue to explore with them, and how we bring pieces together for consumers seamlessly in that experience as well.
So, Anna,
Salma said something
go ahead.
really important about kind of thinking about someone as a whole person, as opposed to just as a as a condition. So if I'm an individual with diabetes, I'm 70% likely to have hypertension. I may have a weight management issue. I may also have depression and anxiety. So how do you, like, if you just had a whole number of apps that you have to go to, it really is an approach where, like, individuals don't want to have to go to multiple places. That's why you have suites of solutions. I remember, I'll kind of date myself, when you'd go to Lotus 123 for a spreadsheet, and then you might go to Microsoft Word for like word processing or something else. It didn't make sense. And that's why Office exists, because you have all these solutions that are integrated, and it's one experience, you can access them. And I think that's important for sponsors as well, whether it's plans or whether it's employers, to look at ways that they can have some type of unifying framework. Just like when I go into a provider's office, I hate that I have to fill out the same forms over and over and over. Like, you know me, I was here like 3 weeks ago, and you're asking me whether or not, like, my insurance, and let's go through all my medications again. Like how does that make sense? And so we have to build, consumer experiences that allow us to just log in and use my face as my ID and let me into the system and get on with it.
And on that point, I completely agree. I agree with you. That experience of going to one system, but still having to fill out the form multiple times because it's an affiliated practice as opposed to an integrated practice is really challenging. We're also partnering with Epic on a payer platform. Again, how do we create that platform for our providers that take risk and are participating in value-based programs to create an integrated experience for customers? And how do we think about it in a world that's predominantly fee-for-service for employer groups? The Epic investment is really about that tie-in between the health plan and the consumer and the physician, to allow for more seamless prior authorization, to allow for ready access to records so that we're not knocking on the provider's door asking for information about their quality adherence and standards. So I think we've got some effort underway, and we have several Chicago-based systems that are working with us on it, including Access Health and FQHC that we're partnering with pretty closely. And I would say, there's a lot to do there in that particular space, and then the way that we create that seamless experience for customers when they show up at the doctor's office.
So Anna, the dialogue between Lee and Salma right there is kind of highlighting a point that for many people, most people, many of the interactions with the healthcare system are not that great compared to other consumer experiences, other experiences that people have. You shared with me the other day a statistic that I found mind-boggling, which is that 82% of American households have Amazon Prime subscriptions, and Amazon is both, I think, renowned for creating a pretty amazing consumer experience from end to end, and is moving more into healthcare. So wondering, as we talk about access, where do you see that heading?
Yeah, and I'm smiling a little bit, Lee, because we made an investment in Freesia, which is now a public company, but they used to have orange tablets for check-in, and we made the investment around 2009, early 2009, as like the iPhone was gaining steam, and everyone was like, this company's dead on arrival. This problem is going to be solved before they can, get out of the gate, and that certainly wasn't reality. And I think we're still sitting here today filling out a lot of forms by paper. So, I
did the first integration with IAM into our electronic health records and practice management systems. So yeah. I know him really well.
So you think about this one little problem in the established system in healthcare around paperwork, which is like one of the most well-documented consumer frustrations in engaging with the healthcare system. And we're still sitting here 15 years later, problem not solved. In the meantime, Uber, Amazon, everything you want on your iPhone, like consumers are just expecting more, full stop. And then I think with this number, I'm probably going to get it wrong, but a 240% increase over the last 12 years or so on deductibles, where wages, have increased, single digit percentages. And so it's no wonder that there is this sort of tipping point, I think, finally in healthcare, where consumers are saying, if I'm going out of pocket and paying, I'm not going to go sit in a waiting room and fill out a form. I've now experienced telemedicine and see that there are these access points that are delightful and easy. Cost transparency. I know what I'm going to pay. I'm going to pay up front. I'm not going to get multiple bills. And so I do think it is this question of like, what is the future of benefits and how do you structure coverage and insurance and funding of these healthcare services in a way that taps into these consumer experiences, whether it's Amazon creating them or local health systems, this expectation of I can go online, get really curated, helpful navigation to an endpoint that I actually care about, which is a prescription, a diagnostic test, a therapy session that makes me feel better. But it's those endpoints and a focus on those endpoints and how do you most efficiently, both from a cost and time and abrasion, how do you most quickly get there? And so I do think it is the decade, I hope, this is the decade where a lot of the sort of things that felt intractable in healthcare really start to shift.
And I have to think, or at least maybe it's just hope, but as healthcare becomes more responsive to the needs of people and the experience that people have, that actually does have an effect on access and does have an effect on equity. And there are examples that I think each of you have given over the course of that conversation that sort of elicit that, whether it's meeting people where they are in a barbershop or creating an end-to-end experience like Levongo had with multiple conditions and not requiring people to dip into different services for different aspects of themselves in the way that they think of it, to a number of the things, Salma, that you shared, that how BlueCross BlueShield of Illinois is working in communities. So I think that may be a good place to wrap up, and I'll thank all of you for your thoughts and opinions and perspectives that you shared in this conversation. I really enjoyed it, and I'll turn it back to Megan.
Thank you so much, Stephen. I would love to reiterate your gratitude to our excellent panelists, Anna, Salma, and Lee. Thank you for your time. Really, really robust discussion. And thank you, Stephen, for your leadership and leading this discussion and all of your commitment to really investing in a better and healthier future for all of us. The recording and recap for this event will be available on our website under Insights over the next few days. Additionally, I encourage you to check back to our website for a follow-up for our events. We have a few in May that will be announced over the next few days, centered around clinician burnout, safe return to care, and enhancing behavioral health safety net. So stay tuned for more on all of those things. But thank you all so much for spending your morning with us, and I wish you all a great day.